Hi, everybody. We'll talk today about cardiovascular meds. I'm going to start by showing a short video on hyperlipidemia, elevated lipid levels in the blood. The narrator will also describe the relationship between these elevated lipid levels and the development of hypertension.
If you have hyperlipidemia, commonly known as high cholesterol, you have high levels of lipids in your blood. Lipids are fats and fat-like substances. In this condition, the most common types of lipids are cholesterol and triglycerides. Your body needs cholesterol to function properly. It makes all the cholesterol you need, mostly in your liver. The cells in your body need cholesterol as part of their cell membrane. Your skin uses sunlight and cholesterol to make vitamin D. Certain glands, such as the testicles in men and the adrenal glands, use cholesterol to make important chemicals called hormones. And your liver uses cholesterol to make bile acids, which help to digest fat in the food you eat. Your body uses triglycerides for energy. Triglycerides in your blood come from food and your liver. Foods high in triglycerides include fatty foods, refined carbohydrates, foods high in simple sugars, and alcohol. From your liver, your lipids are not able to move through your bloodstream without some adjustment. To enable their movement, your liver wraps certain proteins around the lipids. The resulting new molecule, called a lipoprotein, can move through your bloodstream and throughout your body to the cells that need it. Depending on which type of lipoprotein your cholesterol is part of, determines whether your cholesterol is good or bad. For example, your liver makes very low-density lipoproteins, or VLDLs, which are the source of bad cholesterol, or LDL. These lipoproteins are stuffed with cholesterol and triglycerides. VLDL travels through your bloodstream, delivering triglycerides to your cells, which use them for energy. If your liver makes more VLDL than your body needs for energy, the VLDL stores the extra triglycerides as body fat. After losing its triglycerides, a VLDL becomes a low-density lipoprotein, or LDL. LDL travels through your bloodstream, delivering cholesterol to the cells that need it. If your body makes too much LDL, it can build up in your blood. LDL can deposit in the walls of your blood vessels, causing a buildup of fatty material called plaque. Damage to vessel walls can make it easier for LDL to form plaques. Over time, this buildup can narrow the blood vessel and reduce blood flow. This is why LDL is called the bad cholesterol. A common place this plaque can build up is in your coronary arteries, which are the blood vessels that feed your heart muscle. This buildup causes coronary artery disease and increases your risk of a heart attack. Plaque in other arteries, such as the carotid arteries in your neck, can reduce blood flow to your brain and increase the risk of a stroke. Your liver also makes high-density lipoprotein, or HDL, also known as the good cholesterol. HDL has more protein and very little cholesterol and triglycerides compared to LDL. HDL helps remove excess cholesterol from your cells and from plaque in your blood vessels. This is why HDL is called the good cholesterol. HDL returns the excess cholesterol to your liver, which removes it from your body. If you are 20 years of age or older, the National Institutes of Health recommends you have a blood test every 5 years called a fasting lipoprotein profile. It measures your levels of total cholesterol, LDL, HDL, and triglycerides. During this test, a blood sample will be taken from your arm or finger after you have not eaten for 9 to 12 hours. The total cholesterol goal should be less than 200 milligrams per deciliter. For most people, an ideal HDL or good cholesterol should be 60 or higher. An ideal LDL or bad cholesterol should be less than 100. And fasting triglycerides should be less than 150. Your specific goals may vary depending on your health situation. Ask your doctor what your lipid goals should be. If your cholesterol levels are too high, it's important to eat a heart-healthy diet with lean sources of protein and plenty of fruits and vegetables. Also, the types of fats you eat can affect your cholesterol level. For example, saturated fats and trans fats tend to raise LDL cholesterol in your blood. These fats are usually solid at room temperature and are found in meat and dairy products, many processed foods, and tropical oils such as coconut oil, palm oil, and cocoa butter. Unsaturated fats, including polyunsaturated and monounsaturated fats, are healthier fats that are usually more liquid at room temperature. They are found in foods such as fish, nuts, and vegetable oils. Other lifestyle decisions you can make to help your cholesterol are not smoking and getting regular exercise, such as brisk walking or running. If lifestyle changes can't reduce your cholesterol levels enough, your doctor may prescribe certain medications to reduce it. Statins are drugs that reduce the amount of cholesterol made in your liver. They affect LDL levels more than HDL or triglyceride levels. Niacin reduces LDL cholesterol and triglycerides and increases HDL cholesterol made in your liver. Bile acid-binding resins are drugs that prevent the reuse of bile after helping to digest your food. As a result, your liver uses more cholesterol to replace the lost bile, which means less cholesterol in your bloodstream. Fibrates are mainly used to reduce triglyceride levels in your blood, but they can also raise HDL levels. Cholesterol absorption inhibitors reduce the amount of cholesterol absorbed by your intestines from the food you eat. In many cases, the same steps can help maintain healthy cholesterol and triglyceride levels, such as eating a diet low in saturated fat, trans fat, and cholesterol, getting regular exercise, managing your weight, and not smoking.
Many factors lead to cardiovascular disease, like smoking and sedentary lifestyle. There are also very strong indications that excessive low-density lipids, or lousy lipids, can lead to cardiovascular disorders. Lipids deposit in blood vessels and form atheromas, or plaques, that trigger an inflammatory process. White blood cells and lipids collect and damage the endothelium. The vessels become narrowed, so the heart has to pump harder. The vessels also thicken and are less able to dilate, so blood pressure increases. The atheromas can rupture and cause blockages in the brain, heart, or lungs. As the narrator said, we want to keep our total cholesterol less than 200 milligrams per deciliter. Our low-density lipids, those lipids thought to cause that inflammatory process, should be lower than 100 milligrams per deciliter. LDLs are broken down for energy in the body or stored. They derive their name because their proportion of lipids is greater than the amount of protein in each molecule. Elevated LDL levels lead to many of the diseases listed on this slide: coronary artery disease, hypertension, myocardial infarction, and cerebrovascular accident. High-density lipids, or HDLs, contain more protein than lipids within each molecule. They work to prevent the buildup of LDLs by cleaning up any remnants of LDLs that remain. Elevated levels of high-density lipids are thought to be cardioprotective. Exercise helps to increase HDLs. Very low-density lipids, or VLDLs, contain a high proportion of triglycerides. Their levels are determined by carbohydrate intake. When a client has elevated LDLs and VLDLs, there is a need to change their lifestyle. If lifestyle changes don't work, then there is also a need for pharmacotherapy. About 11 million Americans use statins like simvastatin or pravastatin. This class of medication works by inhibiting the enzyme necessary to produce cholesterol. The effect of the med is to increase HDLs, the good cholesterol, to reduce LDLs, and to a lesser extent, reduce the VLDLs and triglycerides. It takes about 4 to 6 weeks to achieve maximum effect. An important teaching point here: most statins are administered in the evening. This is so the peak coincides with the time cholesterol is formed in the liver, which is between midnight and 3 a.m. If a higher dose is needed, then an additional dose might be given in the morning. While a person is taking a statin, we'll be monitoring their serum lipid levels. We will also need to monitor liver function tests. There is a risk for hepatotoxicity with statins. The med is used very cautiously with clients that have liver impairments. Clients are taught to avoid acetaminophen and alcohol. Clients are also taught to report muscle pain, especially in the legs, weakness, and malaise to the provider. These could be indications of hepatotoxicity. If ALT and AST levels reach 3 times the normal levels, then the medication is stopped. Research has shown that statins don't necessarily extend the lives of older adults. There's also potential risk for memory loss and confusion in the older adult, so the decision to prescribe to this group is done after a benefit versus risk comparison. The most common side effects concern the GI system, usually GI upset or constipation. Other potential adverse effects are photosensitivity, so teach your client they should wear hats, sunscreen, and stay out of the sun during the hottest part of the day. Rhabdomyolysis is a rare adverse effect where skeletal muscle is broken down and excreted in the urine, causing the urine to have a tea or cola-colored aspect. This is an emergency situation, so the client should seek immediate care. Cholesterols, among their other functions, help to form bile acids that help to digest fats. The bile acids absorb lipids from the diet, and then the lipids are reabsorbed in the small intestine. Bile acid sequestrants work by binding to bile acid. The larger complexes that form are unable to be absorbed in the small intestines and are then excreted in the feces. The adverse effects will primarily concern the GI tract: nausea, vomiting, diarrhea, constipation, abdominal discomfort, possible vitamin deficiencies, since absorption could be impaired. Sequestrants like Questran can bind to other medications. Clients are instructed to take other medications either 1 hour before or 4 hours after the bile acid sequestrants. Cholestyramine, a bile acid sequestrant, should be mixed with liquids and might need to be taken up to 6 times a day. So the medication regimen is more complex than that of the statins. Hypertension is a significant health problem in the United States. 65 million Americans have it. About 1/3 of that 65 million do not realize they have it, and 2/3 of those being treated don't keep their blood pressure below 140/90. Many who have it have no signs and symptoms, although occasionally there can be headaches. 60 million are pre-hypertensive, meaning their blood pressure measures above 120/80. If they fail to make lifestyle changes, they can develop hypertension. Although the causes of primary hypertension are unknown, there are risk factors like smoking, obesity, sedentary lifestyle, high fat, high sodium diets, alcohol use, and elevated serum lipid levels. Secondary hypertension can occur in response to kidney disease or meds like oral contraceptives, steroids, or erythropoietin. Clients with repeated blood pressures above 120/80 are classified as prehypertensive and are strongly encouraged to make lifestyle changes like weight loss, smoking cessation, increased exercise, and increasing their intake of fruits and vegetables. If BP doesn't decrease as a result of the lifestyle changes, a medication might still be necessary. With stage 1 hypertension, repeated blood pressures in the range of 140/90 to 159/99 would warrant the administration of one antihypertensive. The client is started on a low dose that would be increased until the goal is reached. More than one medication might be necessary. In stage 2 hypertension, more than one medication would be indicated. Let's take a step back here and talk about how several organ systems work together to maintain a normal range of blood pressure. The organ systems would be the central nervous system, autonomic nervous system, kidneys, and endocrine system. Baroreceptors in the blood vessels are sensitive to decreases in blood pressure. When pressure drops, signals are sent from the baroreceptors to the medulla oblongata, what we call the vasomotor center. The sympathetic nervous system is activated, and the alpha-1 receptors in blood vessels are stimulated. Vasoconstriction occurs. A drop in glomerular filtration rate, which corresponds with a drop in blood pressure, will cause the kidneys to retain sodium and water and increase blood pressure and cardiac output. The renin, angiotensin, aldosterone system is also activated in response to decreased fluid volume. The kidneys will release renin in response to elevated serum sodium and decreased blood pressure. Angiotensin 1 is then converted into angiotensin 2 thanks to the enzyme, angiotensin converting enzyme. Angiotensin 2 is a very potent vasoconstrictor, and blood pressure increases. The final step in the system is the release of aldosterone, which is a hormone secreted by the adrenal gland. Aldosterone causes the body to retain sodium and water and to release potassium. Because there are different mechanisms at work to maintain blood pressure, there are different classes of medications used to treat hypertension. Some target sympathetic nervous system action, others the renin-angiotensin-aldosterone system. Still others, the nephrons of the kidneys. Some medications reduce preload, which is the amount of blood entering the ventricles. Others will decrease afterload, the amount of resistance as blood leaves the heart. Whatever the medication, clients need to also make lifestyle changes to control their hypertension. One of the goals of pharmacotherapy for hypertension is to prevent complications associated with the disease. This makes the ACE inhibitors a good choice for primary medication. ACE inhibitors are renal protective. They protect the kidneys against the harmful effect of the disease. They also protect the intima, the innermost layer of blood vessels. ACE inhibitors, like enalapril, help to reduce the vasoconstrictive effects of angiotensin 2 since it interferes with the enzyme that allows its production. The result is vasodilation, which reduces blood pressure. In addition to treating hypertension, ACE inhibitors also treat heart failure and myocardial infarction. ACE inhibitors are prodrugs. When swallowed, they are in an inert form. They must be metabolized to convert into an active form. For those with liver impairment, lisinopril would be given. ACE inhibitors tend to be well tolerated. They do not affect cardiac reflexes, and although there is a slight risk for hyperkalemia, electrolyte imbalances are rare. The more common adverse effects center around postural hypotension, especially after the first dose. We can avoid this by giving an initial lower dose and then increasing the amount. A dry, persistent cough occurs, especially during the first few days of taking the medication. The cough is caused by bradykinin, a pro-inflammatory agent. A more serious effect is angioedema, or swelling around the eyes, mouth, and throat that can spread to the airways. If it does happen, it is most likely to occur in the first day or two after starting the medication. In rare occurrences, the angioedema can happen months or even years later. If angioedema occurs, or if the dry cough is too bothersome, the client could be switched to an angiotensin 2 receptor blocker. These meds, which would include losartan, bind to angiotensin II receptor sites in the arteriole and result in the lowering of blood pressure. There is no cough, no edema, although the hypotension is still possible. Aldosterone antagonists, like spironolactone, block the action of aldosterone. They block the aldosterone from binding to receptor sites in the kidneys. Although this action does block the reabsorption of sodium in water, there's an added risk here for hyperkalemia. Normally, when cardiac cells and arterial smooth muscles receive an action potential, it results in calcium entering the cell and causing muscle to contract. Calcium channel blockers interfere with this movement of calcium into cells. When calcium's movement is blocked, the smooth muscle relaxes. Blood pressure drops. When the movement of calcium is blocked in the heart, coronary arteries dilate. Less oxygen is used by the heart, and heart rate decreases. Some calcium channel blockers work on both the heart and arterioles, like verapamil. Others, like nifedipine, are selective and target the arterioles. Calcium channel blockers can also be used to treat dysrhythmias like atrial flutter. The side effects of calcium channel blockers can be hypertension, peripheral edema, dizziness, and headache. Because the vasodilatory effects can cause pooling, peripheral edema can occur. Constipation is also possible, since smooth muscles can relax along the digestive tract. The most serious effects for which to assess would be heart failure or reflex tachycardia. I won't talk too much about adrenergic antagonists since we covered the topic in week 2. Just a couple of extra points. These meds can have multiple effects on cardiovascular functioning. They decrease heart rate and contractility, so they reduce cardiac output, which make them good choices for treatment of angina and dysrhythmias. Severe problems can occur on high doses of adrenergic antagonists. Heart rate can decrease to the point where heart failure can occur. Clients report activity intolerance at high doses. Rebound hypertension can occur with abrupt cessation, so the client's dose must be tapered. Diuretics can also be used for treatment of hypertension. They are indicated in treatment for heart failure and renal failure as well. Diuretics have a similar mechanism of action. They target the nephron, where they block reabsorption of water and electrolytes, and more urine is produced. The result is a lowering of blood pressure due to a decrease in fluid volume. Diuretics have different levels of potency, and the potency depends on where in the nephron they exert their action. Meds that work earlier in the nephron have greater diuretic effects. Loop diuretics that prevent reabsorption in the loop of Henle will produce a stronger diuresis than thiazides, which target the distal tubules. Loop diuretics have the strongest action in this class of medications. With the greater diuresis comes a greater drop in blood pressure. Not coincidentally, there is also a greater risk of electrolyte imbalances and dehydration. Generally, loop diuretics are indicated for moderate to severe cases of hypertension. Meds like furosemide are also used to treat CHF, renal failure, and pulmonary edema. Because furosemide will exert its diuretic effect even if blood flow to the kidneys is impaired, it is widely used to treat the fluid retention that accompanies kidney failure and CHF. We mentioned that fluid and electrolyte imbalances can occur with furosemide. In addition, other adverse effects include orthostatic hypotension. Caution must be used when administered along with digoxin. Hypokalemia can lead to digoxin toxicity. Finally, when used with gentamicin, ototoxicity, loss of hearing, could occur, although it is rare. Thiazide diuretics have less diuretic effect and a lesser likelihood of fluid and electrolyte imbalances, although it could happen. They are used as a maintenance diuretic in the treatment of mild to moderate hypertension. It takes about 4 to 6 weeks before thiazides have a full effect, so they don't act anywhere near as quickly as the loop diuretics. They would not be a good choice for renal impairment. When it comes to adverse effects, our biggest concern would be hypokalemia. Clients may need to increase their intake of foods high in potassium or take a potassium supplement. Assess clients carefully who are taking a thiazide along with digoxin. Again, hypokalemia increases the risk of digoxin toxicity. Finally, thiazides are often given along with other antihypertensives, so assess for hypotension. Potassium-sparing diuretics inhibit the action of aldosterone, whose function is to retain sodium in water and release potassium. The outcome is that sodium in fluid is released into the urine, while potassium is retained. Spironolactone is the prototype, and it has less diuretic action and longer onset than the other diuretics. Because potassium is retained, spironolactone is sometimes given to offset the effects of the other diuretics. There is a risk for hyperkalemia, so assess cardiac functioning. Remember that hyperkalemia can result in dysrhythmias that show up on EKGs as peaked T waves. Also, teach clients to avoid salt substitutes that contain potassium chloride in place of sodium chloride. Additionally, ARBs and ACE inhibitors can have additional hyperkalemic effects, so they should be used with caution. Finally, aspirin may increase potassium levels. That can lead to toxicity. Acetaminophen might be a better choice. The most potent antihypertensives are the vasodilators. While the other antihypertensives act on neuronal, hormonal, and renal effects, vasodilators act directly on arterial smooth muscle. They are primarily used for hypertensive crises, although they are also used as maintenance medications for African Americans with hypertension and heart failure. The adverse effects of direct vasodilators can be very serious. Because blood pressure can drop significantly, the body could compensate by increasing the heart rate. Tachycardia could develop. With tachycardia, oxygen supply to the heart might not meet the demand. So beta blockers are often given along with the vasodilators. Another adverse effect, a sharp decrease in blood pressure could activate the renin-angiotensin-aldosterone system, which results in fluid retention. Diuretics are often needed to offset this effect. When used as a maintenance medication, hydralazine is given along with isocyanide dinitrate, an organic nitrate, which dilates the coronary arteries, decreases the oxygen demands on the heart, and reduces cardiac output. A lupus-like syndrome, where symptoms like muscle joint pain along with fever is another serious adverse effect. It's more common in clients receiving higher doses. If these signs manifest, stop the medication immediately. Sodium nitroprusside, or nitropres, is a vasodilator that targets the veins. It is used in hypertensive crisis when blood pressures exceed 180 over 120. Hypertensive crisis could occur as a result of poorly controlled hypertension, abrupt stoppage of antihypertensives, or in certain disease states. The client will need constant monitoring while on this med. It works within minutes when given IV. Because of the pooling that occurs, perfusion of the brain, heart, or kidneys could be disrupted. Also, the medication breaks down into cyanide, which is highly toxic. So we use this medication only in emergency situations. Well, thank goodness that's it on antihypertensives. I'll see you at the next lecture.